Hi, John. Good morning, Harshad. Is
Good
that
evening, good morning. How are you?
good? How are you doing today?
I'm doing well. All well?
Yeah, is Warlick's you here?
Yes.
Are you still flossing?
No.
Where's your camera?
Hold on.
Is Warlick's you here?
When are you starting, John?
Yeah, we start in 15 minutes.
Okay, see you then in 15 minutes.
It depends though. Warlick's is the boss.
She's there. I saw her online.
Yeah, I think she's hiding.
Hiding.
Are you there,
She
Warlick?
can't hide.
There she is.
Okay. She's getting ready for a great show.
Well, you know, she took so long flossing. 15-minute floss. As a resident, I don't think you have time to floss, right? Yeah, let me get off I've got myself highlighted. Hold on, Warlicks. How do I get off this here? Okay. Oh man, this happened before.
So who's gonna ask about the sequence?
Gallery view. Okay. It's a gallery view. Now I want, you can see gallery view, right, Warlicks, right now?
Where?
Okay, I'm trying to get you on.
In the website?
Okay, hold on. I'll make you the spotlight. Add spotlight. Now, how do you get off that? I want to see myself here. I get. Okay. Remove spotlight. Okay. Now that I got
Oh,
you.
here is she. Hi, how are you?
Hi, Doc. Hi, how
How are you?
Yeah, I'm
Nice to
good.
see you.
Nice to see you too.
Good.
How everything?
Good to see you as a co-host.
Yes.
Fantastic. You're doing good job.
Yeah, I'm still John trainee.
Yes.
He can
John is
find.
training you well.
Yeah.
Okay. Okay. Is it changing now? Is my.
Yes, it's changed now.
Okay. I'm sure you're seeing me now or no?
I can see you now.
Oh, okay. Okay. Oh, there we go. Okay. So it goes to you. Harshad, can you speak? Hello, Harshad?
Yes, I can speak.
Okay,
Tell me,
good. Okay, I
John.
just want to make sure the camera goes to the
Yeah,
person.
no, I can speak and I can see you also.
Okay.
Yeah.
Okay, so we're all set up. I thought I had that screwed up. Okay, Warlick, let me just do a few last minute things, okay?
So who gonna tell us the sequence?
We start in about 10 minutes, okay?
Yeah, but the sequence is as a poster, like Professor Juha, Binsu, what else? Chelsea, Marie, Megan, Van.
Yeah, so Warlick's basically, I'll just introduce you and you just, you know, say welcome to NEURO IMC, you know, headed by Luis Lopez-Ibor.
Forget.
It's a bi-monthly NeuroInterventional radiology meeting. And We'll talk to them to see how they want. Here's you now to see how they want to order it. I think we'll let Lewis determine the order. Okay, I think you has first.
I would like to be first.
Hey, how you doing, you?
Hello, hello, hello.
Good morning.
Hello.
Okay.
Good evening from here.
So it's
Good.
gonna be monthly, right? So I have to say that too.
I'm sorry.
So it's gonna be monthly presentations or every 2 weeks.
Every 2 weeks, bi-monthly. That's what it means, right?
Every 2 weeks, so it's gonna be twice per month.
Right.
We have to ask the boss. Louis is the boss.
Yeah. Let me make sure. Let me check with Lewis now. Make sure he's coming in.
Good evening, Professor Juha.
Hello, Boralux.
Hello, Professor Jua. How are you?
I'm fine. I'm fine. Hello, Harsha.
Hi, fine, fine. Good to see you.
Nice to see you. Yeah.
Same here. Looking forward to listen.
I'll just check with Lewis now. How's everything in China? You are same? Oh,
Yeah,
here's-
strict controls continue. Yesterday, 18 COVID cases. So this is in the whole China.
wow, that's amazing.
Really close. It's really
That's
close.
amazing.
But,
Things are getting tighter here.
yeah, certainly.
Again.
Takes a long time that the world will be open.
Yeah. Well, it's good news about the vaccine anyways.
Yeah.
Yeah.
we-
There's 3 now that have been reached the stage 3. 3 drugs. There's going to be more than one vaccine, I guess. Hello, Lewis. He was trying to get in.
Good morning.
Hey, good morning, Lewis. How are you doing?
Hello, Luis.
Hi, good morning. How are you, everybody?
Hi, good.
Hi, Doctora. What are you?
Okay, Warlocks is moderating. Lewis, what's the order of speakers?
At the same in the poster.
Okay, so you has first.
You has first, then Binshu, by.
Dr. Pai is not involved today. He
Okay.
apologizes.
Okay.
Don't
So we
worry.
are only 4.
Okay. Don't
Yeah,
worry.
it's informal, Warlocks. You can just say, "Who's next?"
If you want more time, you
Okay.
I have some videos, 6 videos I will show. It takes maybe 25 minutes.
Perfect.
Yeah, we have lots of time now that Bai is not going to talk. So take your time, Yuha.
Yeah, okay.
I close this.
Were you home, Lewis?
Yes. Is Madrid is
Okay.
Madrid is closed. Only going to the hospital when I have a patient.
Okay, here's Ben.
Because the situation is not clear.
Yeah, well, you know, Lewis, your screen is dark. The lighting,
Yes.
lighting. Yeah, you can see it, right? You can see what I see.
Yes, but I think.
Open the curtains a little
Hello.
bit.
No, I changed the place.
Hey, Ben. Good morning.
Hi.
Hi.
Good morning.
Good morning, Ben.
Hi. Good morning, guys. Can you hear me? This is Joost, please.
Yes.
For some reason, my video is not on. I don't know why, but.
Well, good luck.
Just.
Oh yeah, Dr. Jaws.
Dr. Dross, is that you there?
Yes, that's me, but my video, I don't know.
Okay, just on the bottom left of your screen, there's a picture of a camera. You should click on that.
Yes, I did, but yes.
There
now,
you go. There you
now-
go. There you go.
Yeah.
How you doing?
Very good. Thank you. It's very special, huh? It works very
Yeah.
nice. Thank
Yeah,
you.
I'm Dr. Bennett. I met you a couple of years ago.
Yes, yeah, I know.
Madrid.
Yes, and I see your emails every day.
Yeah, I bother you a lot.
No, it's good.
Well, you know, people that like neurosurgery, they don't mind, you know, but of course, people that don't like it, they get off the list.
Yeah.
Do you know Juha, Jost, right?
I
Yes,
think we have been in some meetings together.
absolutely.
Hello, Josh.
Yeah. Hi.
And of course, you know, Lewis is here, you know, Lewis.
And beginning this year, I met Dr. Binshu in Madrid as well.
Hi.
Oh,
Yes.
Ben, yeah.
Hello.
Hi. Hi. Hello.
Yeah.
Nice to meet you again. Yeah.
Ben is multitasking.
Yeah.
He's translating, and at one point he was screen sharing too.
He is translating in Chinese simultaneously all what we are speaking. So that's why we have that kind of big audience, thanks to Bin.
How many? How big? How many people would you expect?
How many audience?
Yes.
It is around 5,000 last time.
Really? Oh,
Yeah.
Yeah. It's good that you have the time.
wow. Yes, I didn't
It's
know.
5,000, more than 5,000 last time.
Because see you guys, I'm a little bit
Very
over.
popular.
I'm a little
Mostly
bit
Chinese,
overwhelmed.
right, Ben? Mostly Chinese, I think, right? Of that 5,000, I think, right, Ben?
Yeah.
Yeah.
Professor Yasaki had the record, maybe 7,500, and Spätzle close to that.
Wow. Okay, 4 minutes. We start. Just letting some people in. Last minute.
Is that your hospital in the background, or your city? You are, of course. Or is it the hospital?
This is my hospital here.
Yeah.
This is Henan Provincial People's Hospital. This is the second largest hospital in the world.
Oh,
In Chengzhou is the largest hospital in the world. This is the university hospital, our rival. Yes, so because Henan is the most populated province in China, so there are in the capital there are two biggest hospitals in the world. So they are really it is like Yellow River, the patient flow.
wow.
Huge number of cases.
So how many beds do you have in that hospital?
In neurosurgery and endovascular, there are 650.
Wow.
Yeah, that's spectacular.
Well, Ben's hospital.
But Tubin has the largest neurosurgical hospital in the world.
Really?
It is
Maybe.
Huashan Hospital is the largest
Yeah.
one at the moment in Shanghai.
Wow.
Amazing.
Too many
Great
people.
work.
How big is the Huashan Hospital?
Our department, we almost have 800 beds.
Oh, wow.
Only our department. Yeah. So we have 4 campus, and the main campus is West Campus. Now we have 37 operating rooms. So totally, our department have around 40 operating rooms every day.
14. 1 4.
40.
440.
Yes.
Oh.
Yes.
Amazing work. Amazing.
That's spectacular.
Large volume. Very large volume. Great.
Yeah, I know.
Yeah, 2 minutes, we start.
Okay.
And one question, your activity, Professor Bean and Juha, your activity is decreased in this period of pandemic or is the same? Your activity is decreased or you are the same patient?
I think in the beginning of the year was decreased, but now it is normal or increased.
Yes, not in Spain. At the moment, I continue in Madrid. Some problem to programmation.
Yeah, in China is strict measures, but 18 cases yesterday, 18 cases in the whole China with a huge population.
It's amazing.
Amazing. Fantastic.
There's
Fantastic.
more than that in Miami.
We need to learn how from China how to manage that. This
Obey commands, obey commands. This is
yeah,
what the Asian people are doing. They obey commands,
yeah.
not Spain or America or Europe.
Yeah.
Okay, Warlock,
But
you
they
ready?
obey commands. Okay, we go.
Okay, we're going. Ready, everybody? Warlock, you ready?
Yeah.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. It's Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. Today we have number 4 in the Neuro IMC sessions run by Luis Lopez Ibor, NeuroInterventional radiologist from Madrid. And I'll turn it over to the host, Warlocks. Welcome, Warlocks.
Hi. Greeting from the 4 NeuroIMC sessions, the global online communities of NeuroIntervention radiologies. So today we are really present to give you the presentations today. Dr. Luis Lopez is our course director. I am Warlocks. I'm your moderators today, as well as Dr. John Bennett. He is the co-host. Today we have interesting topics about median cerebral artery aneurysms, microsurgery versus endovascular treatment. We have 5 speakers who are specialties in different fields. So we will begin with a surgical part by Professor Juha, the greatest neurovascular surgeons of all times. He has a lot of experience in neurovascular fields. So he will give a talk on the surgical management in the MCA aneurysm part 1. Please, Professor Juha.
All set, Yuha? Oh, I don't know if we lost you. Yuha, are you there? We may have lost.
I'm here,
Oh,
but
okay.
it takes some time to run my videos.
Oh, okay.
Okay. Sorry for the delay. Okay. Okay. You're right. I don't know this one now.
Maybe I can start. Then you.
Yeah, that might be a good idea, Ben.
Okay.
What do you think, Yuha?
Yeah, it's okay. It's okay. We have
Okay.
some technical problems. Please go
Okay.
ahead.
Okay, go.
Okay.
Okay.
Okay, let's move on to Dr. Bin. He also the neurovascular and bypass surgeons from China. He's from Fudan Hospitals. So Dr. Bin will give his talk about the surgical management in the middle cerebral arterial aneurysm part 2. Okay, so thank you, Dr. Bin.
Okay, thank you, Verox. So today my topic is bypass for complex MCA aneurysms. So I come from Shanghai Huashan Hospital. So for the MCA aneurysm, mostly we still use open surgery as a best choice because like this simple, very simple MCA aneurysm, the clip can get very good surgical result and almost don't worry about the recurrence. And sometimes if the MCA, especially the segment of M1 to M2, there's some fetal perforators. So normally we should save the perforators. And like this patient, I use 11 clips to reconstruct the road cavity. So like this patient, I use the vessel, the aneurysm have involved around 300 degrees of the vessel wall. So I use one backside, one frontal side to reconstruct the vessel cavity. But for the giant and the complicated aneurysms, we still need the bypass, especially for the MCA M1 to M2 segment aneurysms. So this is like this patient. Now flow diverter also it's a choice, but still have high risk of bleeding comparison to the clipping. Like this patient is a 10 years old young boy, and big M1 aneurysm. Actually, it's feasible to put a flow diverter in it, and they use a pipeline combined coils. It looks quite good. Everything looks good, but in the afternoon, it got the hemorrhage, and they did the decompressive craniotomy. And this is the final result. Although the final result is quite good, you can see the vessel wall was reconstructed along the flow diverter, but the patient already have some complications. So bypass treatment is a hemodynamic treatment of MCA aneurysms, normally combined with some other procedures like bypass combined proximal direct occlusion of MCA. If the vessel wall was quite thick, and we can consider the distal occlusion of MCA. And the MCA also can combine with trapping of the MCA aneurysms. So the purpose is to decrease the pressure of aneurysm wall, keep the blood flow in perforators. This is very important, and keep the blood flow of distal parent artery. And the protective, sometimes we also use the protective bypass, which use this technique, we can get more time for clipping the aneurysm. So MEPSCP was monitored as a routine in every complex MCA aneurysm. So this is a ICG flow 800 is helpful in selecting the recipient artery. So normally, if you have a hybrid operating room, that's the best choice. You can see this patient, it's MCA giant aneurysm, and we did the distal bypass of the STA-MCA. You can see the blood flow reflux to the aneurysm wall, and but the aneurysm didn't show the large part of the aneurysm wall. So then we combined with the distal clipping of the aneurysm. Actually, the final result was quite good. So for the MCA aneurysm strategies, if it's a fusiform MCA aneurysm, we use non-dissecting fusiform aneurysms. So if the LSA was involved, we will use partial clip trapping combined high flow ECIC bypass. If the LSA was not involved, we will use clip directly reconstructing and sometimes clipping, wrapping. I think wrapping is very important if the 300 degrees of the vessel wall was involved by the aneurysm. So we can use fenestrated clips. I call it like outside of the vessel's stenting. So if you use 2 or 3 this outside fenestrated clip, actually the vessel wall couldn't be expanded anymore. So it's a fusiform dissecting aneurysm with thoracoectotic dissecting aneurysm, or sometimes giant serpentine aneurysms. We will use some blood flow measurement before the surgery. We have the NOVA system, and if the patient only involved the perforators and some MCA territory of the MCA distal territory. So this kind of patient, we use partial trapping combined high flow ECIC bypass. If involved all the bifurcations, if involved the 3 trunks, we can use proximal occlusion with combined bypass. If it involved 2 trunks, we can use proximal occlusion combined high flow ECIC bypass or double STA M2 bypass. So this kind of patient only used in the male patient. The STA was quite larger than 1.2 millimeters. If it's only involved 1 trunk, we can use a partial trapping combined with a low flow, normally STA MCA bypass. If it's a post bifurcation, normally the STA MCA bypass was enough to replace the involved trunk territory. So my personal principles is surgical plan should as simple as possible, bypass time as fast as possible, and the number of the stomas as few as possible. I have some technique notes. Replace enough blood flow for MCA territory or partial replacement. For the male patient, normally 2 STA branches are enough to replace the whole MCA territory. The female patient, normally the STA was quite small. If it's smaller than 1.8 millimeter in the diameter, so we should combine with the radial artery graft. So if the 1 STA branch can create, sometimes we can use 1 STA branch to create double bypass to increase the donor flow. So this is a male patient. You can see normally the 2 MCA branches are enough to replace the MCA, the whole MCA territory. You can see the double bypass was all patent and the blood flow come to M2 segment and replace the whole MCA territory. Sometimes we can use the single branch of STA to create the double barrel bypass, 1 in the superior trunk, 1 in inferior trunk. So before the surgery, we can check the blood flow, the territories of the superior and inferior trunk. So this is type 1 distal ICA to M1 segment. So this kind of patient, we should replace the whole MCA territory and the protection of the perforators. you can see the balloon occlusion test was strongly positive. So use under the MEPSCP monitoring, we can trapping the aneurysm very accurately, and this is MEP STA to radial to MCA bypass combined with trapping of the aneurysm. So we saved all the perforators. So this is the final position of the clips. So this is another case. You can see this is a very giant MCA aneurysm. So this is a female patient. So we use STA radial from the ECA branch to radial to MCA territory, combined with proximal occlusion of the aneurysm. Actually, clip of the parent artery to the proximal distal, proximal end. So this is the second type, unruptured M1 aneurysm with thick wall. So this kind of patient, we can consider the distal occlusion combined distal bypass. So the blood flow replacement should cover the 2M2 segment. So this is after this double bypass, we can see the double bypass was all patent, and one in the superior trunk, one in inferior trunk of MCA. And we clipped distally of the aneurysm. Just after 1 week, we can see the CTA, the aneurysm was closed and didn't show anymore. So even distal MCA superior trunk aneurysm, this is even easier. So we can only replace the superior trunk territories. So this is actually, I finally clipped the vessel cavity perfectly. You can see in this, after the surgery, you can see the vessel cavity was all good, but it needs time to get this result. So before the treatment of the direct clipping, I made the distal STA to M4 or M5 bypass. So this can give us more time to reconstruct the vessel cavities. So this is even distal one. You can see this is a superior trunk. Actually, if the patient's vessel was long enough to do the direct bypass from proximal to distal, so I removed the aneurysm and did the end-to-end aneurysms directly. And this is the final result. You can see the vessel wall was reconstructed very well, and there's no aneurysms. So this is even distal involved only small trunk of superior trunk of MCA. So I only use the STA, one chunk of the STA to do the STA to distal MCA bypass, and then we check the vessel patency in the operating room, and we can see the vessel wall, the anastomos was a very good patent and replaced the distal territory of the superior trunk, and then we directly clipped the proximal end of the aneurysm. So this is even distal. You can see this is in the almost in the cervix fissure, and you can see it's quite a large aneurysm. So the vessel wall was so thick, so I don't worry about the rupture of the aneurysm. So I only did the distal clip, combined the distal STA M3 bypass. So you can see the distal clip of the aneurysm combined with distal STA-MCA bypass. So this is another type, hybrid treatment. This is a you can see I use this is involved the LSA on the vessel cavity. So this is quite critical to treat the bypass and occlude the proximal end of the STA, MCA. So I use direct STA-MCA double bypass. Then I close the aneurysm through the MCA M1. You can see after the embolization, the small perforators was all patent in this area. So this patient have no complications. So this is a hybrid treatment of the complex aneurysm. So I also treat, I also test some new graft, like this patient. This is a right GEA. This patient is quite short, and his radial artery was too short to do the direct bypass from MCA to ECA to MCA. So we tried this new graft, and it's quite long. The right GEA can longer than 25 centimeter. So that's enough to do the direct bypass. So this is after the bypass, you can see, we just follow up this patient. The bypass was patent, and the aneurysm didn't show anymore. So this is a post-operative CT. And this is just after the, in 1 week after the surgery, you can see distal occlusion of the aneurysm, and the aneurysm only has a very small endpoint of the M1 segment. So now we already followed up after 6 months. It's quite good, and the aneurysm disappeared. So this is a take-home message. Every MCA complex aneurysm should have a tailored plan for blood flow replacement and the protecting of important perforators. The surgical plan should be as simple as possible. The bypass time should be as fast as possible. Number of the stomas should be as few as possible. One branch of the STA can create double barrel bypass to increase the donor artery. And the radial artery and the right GEA can be used if STA flow was not enough. The distal occlusion of parent artery only used in unruptured thick wall aneurysm with important perforators. And the MEPSEP monitoring is important. And the intraoperative ICG or angiogram is here before. Okay, thank you.
Thank you very much,
Mm-hmm.
Dr. Bin. It's very amazing. Okay, so I think if Dr. Juha is ready, you can be next. Professor?
Could I ask a question?
Oh, yeah, sure. Okay, sorry. Yeah.
Can you hear me?
Yes.
Yes, yes.
So no, I was thank you very much, because this was a very impressive presentation, and I have a small technical question concerning the wrapping of the aneurysm. The aneurysms that you said you do that with the fenestrated clips, huh? Like a
Yes.
fenestrated clip.
Yes.
Do you put like muscle or gauze or stuff also beside the clip placing, so to reinforce the wall, or how do you do it exactly?
Oh yes, depends on the length of the vessel wall. So
Yeah.
if it's quite short, we can directly reconstruct it with the fenestrated clips. But if it's quite long, we can use some dichrome material.
exactly.
yeah, to support the vessel wall.
Okay. Is there any questions from the panelists? You can leave the questions on the chat or in the Q&A box.
Professor Bean, one question. When you finish the anastomosis, you are, how many cases you are restenosis in local stenosis after anastomosis in this type of aneurysm?
You mean in situ direct bypass, direct anastomosis?
Yes,
Only one case. Only one case.
And you treat it with a new surgery, or you treat it by balloon angioplasty?
No. I resected the aneurysm wall totally, directly, and the distal and the proximal end was long enough to do the direct anastomosis.
Okay.
Yeah. Sometimes, if it's not long enough, you can graft one segment of STA. It's another treatment. Yeah.
And you see in your experience, you are the case, you are collateral circulation in lenticulostriate artery. Sometimes there are some loop. Is frequently this?
Yes, this is a most important consideration before the surgery. When we make some surgical plan to protect all the perforators of the M1 segment.
Oh, thank you.
Thank you.
Maybe if there's time, I have also one short question for Professor Bin-Shu concerning the distal aneurysms, like in M3, showed a couple of cases. Would you do in those patients maybe like a balloon test occlusion to see, because sometimes there might be collateral circulation and just occlusion of that branch would be feasible? Is that something you do as a routine, or you have special?
No, actually before the clipping, we sometimes clip the proximal part of the aneurysm and do the ICG to measure the blood flow and the velocity of the blood flow. And if the blood flow came back through from the collateral, and the MEPSCP was quite normal, you can just clip the proximal end of the aneurysm. Yeah, that's same as the balloon occlusion test. Yeah.
Okay, Warlocks.
Okay, Professor Yuha, your turn.
Okay, I hope my videos are now working. I saw 5 or 6 MC aneurysm videos. They are coming from a large material of from Finland, mainly. 22,000 aneurysms, so more than 6,000 were middle cerebral artery aneurysms. And my personal thinking is that these aneurysms should have microsurgical operation. For some reasons, they are different from other aneurysms. I've been thinking why. 2 big branches, and they easily recur. Can you see that?
Yeah, for some reason the screen is enlarged. You see what we're seeing, right? Yes, for some reason the screen is enlarged. Try again. You see what I'm saying, Warlocks, right?
Yes.
We try hard. I don't know what's wrong now today.
Okay. Well, just wait.
It's okay. I think maybe how about only place the control command and minus, it will be improved to anything like
We-
minimize.
Okay. Let's try it again.
Can you see now?
Yeah, looks good so far. Okay, it's just
Okay,
starting.
it's okay.
Okay,
I
yeah.
begin with the unruptured MC aneurysm. Came some years ago to Helsinki for treatment. This middle-aged female. She had a right MC aneurysm, and there was a growing pleb, and that's why she was sent to us for surgery. And this is the surgery: lateral supraorbital flap, right side, simple flap. In 10 minutes, I'm opening the dura. Shows the details here. One burr hole, then 2 cuts, small bone flap, and then after opening the dura, under high magnification, opening the sylvian fissure distally in this unruptured MCA bifurcation aneurysm, and water injection to distend the sylvian fissure. Dissecting the sylvian fissure, short 3 centimeters with Kamiyama scissors and sucker. And soon we see the wall of the aneurysm. It looks very strong here. But there is a very thin pleb. You will soon see after cutting the arachnoid fibers. You will see the thin pleb of the aneurysm. It would rupture there, and it was growing there. That's why the patient came for surgery from Italy. Dissecting around the aneurysm in the small opening of the sylvian fissure. And this is the pleb. It would rupture here. And this was the growing part. So we go distally to the aneurysm to dissect M1 for temporary clip. Temporary clip is going on M1 below the aneurysm, and then we put the J-formed clip, the large broad base of the aneurysm, carefully taking the temporary clip out, and then check the situation. Not all the aneurysm has been taken, isolated from blood circulation. So some part of the aneurysm remains, so we have to add one more J-formed clip here. In this case, I didn't dare to coagulate the aneurysm because of the different quality of wall. One more J-formed clip and then additional small clips to take the rest of the aneurysm away. Small dog ear is taken by a mini clip there, and then we made ICG. And it looked as the Doppler, also good filling of the branches and the aneurysm not filling. The patient was Maria Guglielmi, sister of famous Guido Guglielmi. So that's why I decided that if he's sending patient to aneurysm clipping, then it should be done. So done by open microsurgery. And I can show. I have some control. There's one at the end. I'm sorry, I have so many videos, so I try to manage just with videos, but it is better to select them immediately. So there is a large, can you see it now?
Yes, we can see it.
Yeah, okay, here is a large ruptured MCA bifurcation aneurysm. We see severe subarachnoid hemorrhage and also temporal hematoma, which is very typical for middle cerebral artery aneurysms, making the open microsurgery ideal because you can evacuate the hematoma at the same time and then clip the aneurysm. So this is total treatment. Now different when severe subarachnoid hemorrhage is there. So you see the red angry swollen brain and then Sylvian fissure full of blood, cleaning the field, opening the Sylvian fissure. And now you see the aneurysm wall already. So of course, because of the fresh subarachnoid hemorrhage, the anatomy is totally different. The brain is red, angry, and swollen. And you have to be careful to dissect all the important parts. And of course, because of the fresh rupture, you have to be careful. So this is temporary clip going on the M1. Now over the aneurysm, and now you see that aneurysm is slack. And I'm manipulating the aneurysm. And then put the first clip, pilot clip. I think the angle is not good here. The pilot clip is compressing the aneurysm, making it possible to dissect it more and take hematoma out. And here the aneurysm is opened already at the end. And then clips are replaced several times to take all the base out, changing the clip positions until the whole aneurysm base has been taken and checking the M2s here, that they are open. Many times clipping. You should not be happy with one clipping until the whole aneurysm has been taken. Of course, there are limits. You may continue all the time. So sometimes you have to end, but not if it is unsatisfactory, especially if the branches are not filling. So changing the clips until the result is good. I'm trying to save the origin of the frontal M2 branch. Yeah, it looks that some part of the aneurysm is left, but I'm not extremely happy with this situation, but the patient made good recovery and recovered well after coming in coma. Next case. Let's take here there is a aneurysm that has been coiled earlier. This is also an Italian patient. You can push everything inside the aneurysms, but many times they are recurring, and especially MC aneurysms are recurring. I don't believe so much on the new technology because you need a long time follow-up to see what happens if you have occluded these aneurysms. So you see, this is example. Of course, some years ago, you may say that there is new technology. I was noted by a Chinese webinar that why I'm showing old videos for two reasons. Because I have longer follow-up time, and then second reason, maybe I was better some years ago to do this surgery and I had better patient material to select my cases. So this is the reason. So here you see the compaction of the coils, opening of the aneurysm, and here the difficulty is that the base is not very much, and coils are inside M2. So this is maybe rather bold doing, but I could manage. But in the beginning, you see that the branches were not filling in the ICG. Even I tried my best. So I had to travel with the clips to have the base taken and also the M2 branches filling. So now, I don't think this is the final situation. Hard fighting. See, inside M2, coils are still. So I traveling, taking some part of the base and then taking more coils out. This, after longer time, it is difficult. In fresh cases, it's more easy, but after longer time, they are scarred and inside the vessel wall. So finally, after many trials, I could take the base and save also the flow, but here is coming the flow, yeah. So this is post-progressivity, and there is also DSA angio, showing good filling of the case of the both M2s. There is a giant MC aneurysm because of lack of good skills in bypasses. I was doing mainly direct surgery in this giant aneurysm. This rather long video. I will shorten it. What is good in this giant aneurysm? It is filling totally, so it has no thrombus inside. They are more easy to do than those with thrombus. Those with thrombus are more dangerous. So I skip the craniotomy here. We go direct to the dissection of the Sylvian fissure because you have seen the craniotomy. This is regular lateral supraorbital approach, opening the Sylvian fissure, and you see the strong aneurysm pulsating against my suction. They are very strong aneurysms. So what is important here, if you try to clip them without temporary clips, it is not successful because this strong aneurysm is spitting the clips away. So you have to manage with temporary clips. Kamiyamas scissors here, rather dull, opening arachnoid, and then put the retractor to hold the frontal lip of Sylvian fissure, and then have to find the M1. It is here. This is the key factor to find M1, and then put temporary clip there. This is dissection of the M2, even it is written here M1. This is not right. This is M2. Frontal part, frontal M2. So we have to create place for the clip here. And you see all the time how the aneurysm is pulsating, strongly pulsating. Even the blood pressure is kept rather low, around 100. So now we are going around, and soon we are ready for temporary clips, opening more. And now you have temporary clips there, M1, and then the first clip should be a ring clip, because ring clips, fenestrated clip is not pushed away from the strong aneurysm. So I'm advancing the fenestrated clip deeper. You see, it is not through the base totally. Advancing more and more from venous peelings, and then checking the situation here. Taking a long straight clip to close the fenestration and to take the aneurysm. And some part remains, so we put proximal to the first one, clip, and this is strong aneurysm. So now we take temporary clip out, short time clipping, and because it is not thrombosed, you can manipulate the aneurysm, you can coagulate it down. And then additional clips, because the aneurysm is partially atherosclerotic. You see the yellow part, but you cannot coagulate it totally down, but make it smaller and apply the clips better. And then one final clip, so several clips, 1, 2, 3, 4, 5. Take the aneurysm, and then it is totally occluded. Advancing the clips a little bit, and this is the ICG and Doppler, papaverine. Surgical in the Sylvian fissure, some glue, and the patient made good recovery. And then I think I have 2. This is postoperative CT angio. Next one. Is also a giant aneurysm, MC aneurysm. At this time, I think it is more difficult to do because it's partially thrombosed. The patient has multiple aneurysms, but the operation is directed first to the largest ones. You see here CT angio, but in MRI the aneurysm looks even bigger here, like a tumor.
Oh, okay, I think you fell off the screen share, Juha.
Oh my goodness.
Okay. No, you just fell off. That's okay.
We try our best. Just recently?
Yeah, just happened.
Okay, we try once more.
Yeah.
Same video. Can you see it now?
Yes.
Okay, so this is a patient with multiple aneurysms. We were treating first the largest one, left MCA bifurcation aneurysm. And it is by far larger than in this CT angio, like you will see in the MRI. It is like a tumor compressing the temporal lobe surrounding edema. This is left LSO, a little bit temporal extension, and then we go down, open again under high magnification, the Sylvian fissure, come to the aneurysm. And then temporal eclipse here 2, and then 1. And put also on both M2, temporal eclipse, so total occlusion. And then you open the aneurysm. And of course, there can be no regret. You have to go forwards. You cannot do anything else but to treat the aneurysm. Here we use the cardiac surgeon's clamp, the Bmc clamp, to compress the open aneurysm base partially together to make it possible to clip the aneurysm. So now, see the aneurysm is a little bit bleeding. So we take fenestrated clip. And then replace the temporal eclipse. And then begin to work on the broad, strong base of the aneurysm and empty thrombus with CUSA. And you see the M2 openings. They also have some thrombus there. This is very important because you may push the thrombus back from the aneurysm in M2s. This happened in this case. So we go forwards, clip the aneurysm, and it looks from outside, it looks beautiful. But the vessels are not filling. They are slack and they are not filling in ICG. No vascular patency. So we have to go again, put temporal eclipse again, and make not so tight clipping of the aneurysm base. We have to check the M2 openings here. There's some thrombus inside, and then we go again and replace the clips, and this time successfully. So we could save the base, and the M2 remained patient, and the patient made good recovery, and then we could later do the other aneurysms. Of course, after that kind of complicated surgery, you should not go forward to attack the other aneurysms in the same session, even if it would be technically feasible. So now, not so tight clipping of the base of the aneurysm, and after cleaning of the aneurysm base from thrombus, so the M2s are open, and should check the ICG once more. Doppler. So M2s are now open, aneurysm gone, but of course So retrospectively, you can say that might be better to do a bypass in these cases because this is like an adventure. You have high risk of occlusion of the M2 branches. So these were the cases I wanted to show about direct surgery of middle cerebral artery aneurysms, and I still think that open microsurgery should be done in all of these middle cerebral artery cases, whatever the technology is advancing. Thank you very much.
Thank you, Professor Juha. So any questions from the panelists?
Yeah, so Juha, thank you. Thanks a lot. If I heard you correctly, so you would, if you have a patient with mirror MCA aneurysms, unruptured ones, so you wouldn't do that in one-stage sessions. So is that correct? You would first do one side and then the other?
No. Actually, I have done it many times, and my co-worker Hugo Andrade, who is with me here in China, made his PhD on the contralateral approach in Helsinki. So
Yes.
I have done it many times. It depends on how the MC aneurysm is directed. If it is directed to the Sylvian fissure, so you can do it contralaterally. You have to select the site according to that, and of course it depends also on the length of M1.
Yeah.
Usually there are bifurcation errors. So in my experience, you can do them by carotid bifurcation aneurysms, ophthalmic aneurysms, with contralateral approach. And this were a PhD study of Hugo Andrade, my friend and co-worker here in China.
Thank you. Thank you.
Okay. They have a questions from Dr. Deepak. I believe maybe Dr. Juha or Dr. Bin can answer. He asks, when STA-MCA bypass is required in complex MCA aneurysms?
And this for Subin?
Yeah.
Yeah, I think
Sorry,
so.
can you repeat the
Yes.
question again?
When do we require the STA-MCA bypass in complex MCA aneurysms?
Double bypass, you mean?
No, he did not specify which single or double bypass, only like STA-MCA bypass in complex MCA aneurysm. Which condition?
Yeah, it depends. Actually, I already showed the strategies in the table. Yeah, because it depends on the diameter of the feeding arteries, the feeders, and if it's we think it's enough to replace distal MCA territory, we just use MCA bypass. But STA-MCA. But if it's a female patient, I already insist that the female patient, the STA was quite small. We should use radial artery or combined with the right GEA as a graft.
Okay, I hope that's the answer for Dr. Deepak questions. So next question, it's I think it's for Dr. Juha. He's gone. Maybe Dr. Bin can answer.
Okay, it's all yours, Warlick.
Maybe Dr. Bin can answer.
Who is asking me? Sorry.
Okay, Professor, questions for your fan clubs. Dr. Harshad, he asks, do you use any adenosines while dissecting aneurysm?
Yeah, actually I had a video. Because of the technical difficulties, I skipped. We are using adenosine in the final stages. If the aneurysm is so that you easily see the aneurysm, but more difficult to have a proximal control, then adenosine is a good medication, so you get short, totally slack aneurysm with the stopping of the heart. So I have used it maybe 200 times. So here in China, I'm not allowed to use it. So it is a big lack because here the arteries are very atherosclerotic, so you don't have any, you cannot use temporary clips. So it would be very nice to have the adenosine for a short time.
I never experienced that too. Okay, so next question is from Dr. Pratishier. She asks, why do you apply glue around the clipped aneurysm?
It is maybe coming from a history in earlier times. Clips slipped. Clips may slip. The high-fetch clips were slipping. So this is some historical thing. And also, I close with glue the Sylvian fissure. In this case, I saw clip shafts were long, filling the whole Sylvian fissure. So it looks that it was used to for the clips, but actually it is used to close the Sylvian fissure. This is my strategy. So I close what I have opened.
Okay, I have a question for myself. If mostly the middle cerebral artery aneurysm rupture will come with the intracerebral hemorrhage, what do you think? Like you gonna remove the clot first, or you going to attack the aneurysm first? Because as I see it from your approach, it's very small. I have read a lot of your articles, so I just want to ask your idea about that.
Yeah, if the brain is extremely tight, then I take some hematoma away, but not totally. And I go directly to the aneurysm, through the Sylvian fissure. And then after treating the aneurysm, I take the rest of the hematoma out. If you try to take the totally the hematoma out in the beginning, then you have aneurysm rupture during surgery. So it is wise to take only as much as possible, and then to have a slack brain that you can dissect well. And then after clipping of the aneurysm, take the rest out.
Thank
One
you.
question, Professor Juha. What do you think about the reason of the many neurosurgeons wait to treat the aneurysm, the ruptured aneurysm in acute phase, because have the possibility of the spasm? What do you think about it? You prefer to treat in early phase, you wait, or what do you think about from this discussion in many meetings?
Yeah, this is old discussion. So we began to do acute surgery in 1980 and operate every case as soon as possible. And this is the practice I have been following. Of course, there is a phase then between 4 to 10 days after bleeding. We have some spasm, but we did also operate on these cases with higher blood pressure during the operation. So I think this is what I call cocktail party discussions, because this can be different all around the world. So depending on the society, how long are the distances, how is the admission policy, so it takes a very long time. Like in China, they are coming rather late here through different steps. So you might not have the possibility to operate every case first or second day, like we had in Helsinki, small city, fast transport, good, fast, well-organized hospital, so you could operate even on the same day when they rupture many times. So I didn't wait. So sometimes, of course, if the patient is deteriorating, going downhill, then you should not attack. If the patient is quickly going downhill, then without hematoma, then you should not attack. But this is the only exception.
Yes, in our experience, I treated every patient in acute phase and don't have many cases of spasm. And some case, after you place the coil inside the sac, the spasm disappear. Some case.
It's possible, but in our database material, so 2% of the all patients with ruptured aneurysm died in vasospasm, whatever we did, and 15% were invalidized, whatever we did. So this is the long-term follow-up and very good follow-up, like is possible, at least in Helsinki, but hopefully in many other places, but seldom you see long-term follow-up. It's more speaking, not real data.
Where is the effect of the papaverine inside the infusion papaverine inside of aneurysm? Because the papaverine in intravascular injection of papaverine don't work well.
I think we are using in surgery because the manipulation causes spasm and it relieves the manipulation spasm, but it is not useful for vasospasm generally. So if you inject intraarterial, so it is not no more working. This is my experience and thinking.
I agree. Okay, thank you.
Okay, Warlocks.
Okay, there's more questions from Dr. Harshad. I think 3 questions. So first question, he asks like the directions of the Sylvan Fisher dissections. Would you prefer proximal first or distal? Or in which direction?
When I was senior resident, I didn't understand why the seniors were going down and then came back. So I began to do, when I did my first aneurysm, I began to dissect distally. And I have done it in more than, how many aneurysms? More 2,500 MC aneurysms. I have always opened the Sylvan Fisher distally, because you can have a good control if you look carefully on the angios, so you will come very well to the control of M1. So distally is my saying. And what was the other question?
Okay, and he asks, how often do you see the post-operative vasospasms?
When you operate early, the first days, you see seldom. But if you operate later, then you might see severe vasospasm.
Okay, and what if they are the operative vasospasm? Do you use nimodipines for management post-operative?
Nimodipine was the protocol in Helsinki and also in Kuopio because of the PhD of Juha Ehrman, who was a professor of neurosurgery, became later professor of neurosurgery in Tampere. He made his PhD on nimodipine. And after that, it was tradition in Helsinki and other centers in Finland to give always nimodipine intravenously or later peroral. Locally, I have never used.
No. Yeah, thank you. Any other questions from the panelists?
No.
Thank you.
Okay, thank you, Professor Juha. So we move on to our next speaker. I believe is Dr. Joost. He is the neurointerventionist from Radboud University's Medical Center from Netherlands. He will give a speech on his endovascular management experience in middle cerebral arteries aneurysm part 1. Okay, thank you.
Thank you.
Please, Dr. Joost.
Thank you very much for having the opportunity to talk. Thank you, Luis Lopez Ibor, for organizing, and I hope I have here spelled the Chinese characters correctly for the Chinese people that are watching, also the Spanish and Latin American people. Please forgive me if it's not correct. That's where my disclosure is. So we move on now to endovascular management of the MCA aneurysms. And well, to tell you, I am a hybrid neurosurgeon, so dual trained, doing both open and endovascular procedures. So I will start first a little bit talking also about open procedures and how we balance and how we decide to do either open or endovascular procedure. So I'm from Nijmegen. That's a nice city, old city in the Netherlands. For those people that don't know my country, it's in the northwest of Europe. And it's a tiny country, of course. So I completely agree with the previous speakers that the most appropriate device for the majority of MCA aneurysms still is absolutely a clip. And why is that? Because it's safe and it's effective. If you divide it on to different locations for treatment choice, the group from Johannes Niemius Helsinki had by location made 4 groups of MCA aneurysms, and I think that's very helpful. And if you make the 2 distal groups in one group, that means the bifurcation and the distal MCA. In most of the cases, that is open surgery with clipping or other procedures. But the more proximal ones at the M1, it really depends upon the anatomy, and there's mostly the issue of the lenticulus triad. So why the MCA bifurcation clipping? Because it's very safe, because they're rarely perforators, and it's more efficacious if compared to endovascular solutions, and that's because of the majority of those MCA bifurcation aneurysms has a wide neck. So actually that was already studied and proven in many studies, and you see it also here in a meta-analysis of more than of about 2,000 patients that were evaluated. So the high safety and efficacy of surgical clipping. So here at our institution, we try, of course, further to improve the clipping by means of safety and efficacy. And we think for vulnerable patients or complex patients, we think awake surgery is very helpful to get feedback how the patient is doing or how effective your clipping is. And beside that, we are very happy with the hybrid room, of course, to get feedback of with your intraoperative DSA. So this is a simple setup of in our hybrid room of a lady that had a severe cardiopulmonary disease. We discussed with the anesthesiology, and they said, well, we cannot put this lady under general anesthesia. So this is under local anesthesia. Here is one of the nursing staff is taking care of the lady. She is even not under conscious sedation, just local anesthesia. And she's doing also some regular neurologic checkups. And here, basically, you see there's an PCOM aneurysm with a severe atherosclerosis as well, and a tiny MCA. The MCA aneurysm was clipped. That was, as expected, uneventful, but we put a clip here on the PCOM, and she neurologically deteriorated, although there was a normal finding with the ICG, especially of the anterior choroid artery. So we did further dissections, etc. But when we put a clip, did repositioning, she still had repeatedly neurological deficits. So we finally end up coiling that aneurysm. So that's an example of that awake surgery can help you. We think that for MCA aneurysms, the age is not that important. Maybe for other locations that could be of importance, but here even old patients we think can be clipped. Here it is an MCA bifurcation aneurysm, typically a wide neck, maybe type 3 or 4. So you get immediately after clip ablation your feedback that the especially the 3D rotational angiography is helpful. This is a case, also an unruptured aneurysm, where clip repositioning was needed, and where the DSA was very helpful, because we put a clip and the basically the ICG and Doppler showed complete occlusion, but here you see a tiny blush. So there's a need for a second clip. So that's what we did. We put here the second clip and then check again. And now it's okay. Those are severely atherosclerotic calcified bifurcation. That was probably the reason that the first clip was not enough. So dual trained hybrid neurosurgeons are rare in Europe. And so we wanted to inspire our colleagues and decided to collect our results and to publish that, to inspire our colleagues to do it, become also like hybrid. So we collected 356 patient ruptured aneurysms and evaluated our results. And for this talk, interesting, what we found was 1/3 of the MC aneurysms we treated by endovascular means. And so there was a recurrence rate of about 13%. So 1/3, we thought that was a little bit too high for MCA aneurysm. So now we moved back or shifted back to more open surgery for those MCA aneurysms. Of course, it's not always perfect. This is a lady came in very bad condition in our hospital, WFNS5, and this is a fatal complication. Actually, it never occurred to me in all the 30 years before, but you need to have every complication once. So she went for clipping. It's like a 2 centimeter aneurysm. We took out the hematoma, and there were a lot of issues with clip positioning, and I had a tear at the neck, lost the branch, many temporary clippings, and so basically we ended up said, well, we're a little bit concerned of her fate, so we took out the bone flap, put an EVD also for pressure monitoring. It looked pretty stable the first day, but the second day she started to increase with her ICP, and she had the CT scan, complete MCA infarction with hemorrhagic transformation. Took that out, debulked it, removed the necrotic tissue. ICP was well then next days, but she didn't improve in her neurologic condition. So that's after 2 weeks, complete MCA infarction. And so we withdrew the therapy and she passed away. So, but overall, I think our experience with the clipping of the MCA aneurysm, whatever location of the MCA, it's safe and efficacious. It's feasible on old patients, and in complex patients or vulnerable patients, consider awake surgery. And we think the hybrid room and intraoperative DSA is very, very helpful. Although neurologic deficits are very rare, a substantial amount of patients do complain of postoperative headaches or fatigue. So, and they say that's a huge difference if they have also been treated endovascular with an endovascular technique. So we move forward now to endovascular strategy, and this is a case similar to what Professor Bingshu showed previously, and that shows that it's very nice to be a hybrid or a dual-trained neurosurgeon. This is a complex MCA aneurysm, partly thrombosed of the inferior trunk of the M2. Also. And so here, this is not a case for a standard technique. So here the decision was to occlude this branch, the diseased branch, and to do a low flow STA MCA bypass. So with the help of navigation techniques, we choose the right craniotomy site, go in with a microcatheter and do a selective injection to the diseased branch to look to find the recipient artery, which you can see here now, do the bypass, and then have occlude the diseased branch, occlude the aneurysm. And so we end up with a nice remodeling of the left MCA territory. So endovascular options, next part of my presentation. So Basically, the last 10 years, especially, there are so many new devices, all kind of devices, that it's very difficult to choose, and especially also in Europe, it's easy to get CE approval. So you have so many devices, it's very difficult to choose which one would be the best. And so there are so many options. But of course, like, so you have here the balloon, then the stents, then the intersaccular devices, web contour, P-conus, pulse rider, floater-vertus, and the floater-verter-like implant called Eclipse. So I like the last 10 years, and definitely 10 years ago, we were very inspired by all those promising devices, and we wanted to use them because, well, we thought probably there are good solutions for any aneurysm because it's not very invasive therapy. So to start, I will go through the different endovascular options we have and the experience at our institution. So bare coiling for an MC aneurysm is definitely possible, but you need a favorable dome neck ratio, or at least more than 2. You can do it if there's an open neurosurgical contraindication, or if the patient refuses open neurosurgery, and this is not rare in our culture. The problem is that the favorable dome neck ratio is very rare. It's about only 10% of the cases you will see that. But neurosurgical contraindications, for example, here in an acute case, very old patient with WFNS4. So here we thought it might be better to choose a less invasive short procedure for this MC aneurysm. Just put a couple of coils in, and that is for this lady, probably the best, and see if she recovers. Here, probably we made, I think, hindsight, not a very wise decision. This is a young male, multiple aneurysms, but a ruptured left MCA aneurysm. We thought, well, the dome neck ratio is favorable, and neck is not wide, but well, this is definitely also a surgical case, probably. But so we called that. It looked pretty okay, but the first, second, and third year post-op looked good in the MR, but the 4th year, there was a recurrence, and now it's a wide neck. And what Professor Henry showed, it's not always easy. We did that also like 10, 15, 20 years ago, do clipping after a previous coiling, but when the clips are very close to the neck, and there's also atherosclerosis, that is pretty difficult and tricky to get thromboembolic complications, etc. So we don't like to do it anymore. So here, and now there are better stents as compared to 15 years ago and 10 years ago. So we decided here to put for the recurrent aneurysm, put an Atlas stent. So now it's easier to put stents and to coil it. So this is the final result. We see how it looks in the next year. This is a similar problem of a patient that had a ruptured MCA in France, had a bare coiling in France, and then rebled 6 months later and was retreated with a bare coiling. She moved to the Netherlands. Now she came to us, and here you see again, you have a problem now with the coils, and it's a very wide neck of about 7 millimeter. And the coils are unfortunately very close to the neck at this area. So we think clipping could become very complex. So because it's a very wide neck, we think stent-assisted coiling here is not very helpful. I will explain later why we think it's not very helpful. So we just did a bare coiling. Here the neck is more than 7 millimeters, and well, it's not very perfect. We're pretty conservative, and as expected, yet recurrency 2 years later. So that was this year, 4 years after the first coiling. She's doing fine, but because of the recurrency, we said we need to coil again. So now we're a little bit more aggressive as compared to the previous coiling. But the problem with stent-assisted coiling, as we see it at our institution, we studied our recent stent-assisted coilings, and so now it's easier to use stents because, for example, the Atlas stent It comes in an 017 catheter, which is easy to navigate, and it are so easy to use stents now. But still, the problem is that that's what we found in our series, that as soon as the neck is more than 4 millimeter, you find only in 1/3 of the cases a complete occlusion at follow-up. And these are results scored by an independent reviewer. So maybe web is the solution. Of course, like many others, we thought, well, web, we are inspired by the web because it's also, again, it's easy to use. So here, this patient, ruptured MCA, 8 millimeters dome, 4 millimeter neck. So we put an 8.5 web, and actually it looks beautiful. So we get a nice thrombosis, and here the positioning of the web, it seems to fit pretty nice. So we are very happy. At 1 year follow-up, it looked nice, but at 2-year follow-up, you get collapse of the web. You get like a new aneurysm. So it needs to be retreated because he has had a history of subarachnoid hemorrhage. And so we advised her to do surgical clipping because now it's that there's enough space below the web, but she didn't want to be clipped. So we did here Y stenting and coiling, and actually that looked pretty nice. At 1 year follow-up, it still looks okay. So we have to see how it looks with further follow-up. So this was pretty effective now. Pulse rider, limited experience, but he has an MCA case with 2 lobes, and you put the pulse rider, and through the pulse rider you can coil, and here we get a good complete occlusion, which at follow-up state also has a Raymond 1. Unfortunately, the patient had a thrombembolic complication, but the patient recovered from that thrombembolic complication. So at our institution for MCA aneurysms, we have no experience with the other devices. So in summary, the results of stent-assisted coiling in the literature, there is a recent systematic review performed, and their conclusion is, so they see a long-term complete or near complete occlusion rate of a little bit more than 70%. That is maybe okay, but in aneurysms where there is also a surgical option, I think that's not enough, and that's also their conclusion. It's not ideal. That's more than 2,000 patients that were reviewed. Another thing is, most of the studies in this systematic review are retrospective studies with operator-assessed data. So that makes a difference. That was also documented in other reports, but also here specifically for wide-necked bifurcation aneurysms. There's a difference between operator-assessed or self-assessed data and core lab results. And you see here, that's a difference in about 10% in the efficacy, so complete occlusion from operator-assessed studies and independent reviewer. So this is like trials. So, of course, the recent devices have been, I think, probably better studied. As absolutely, the web the results have been documented in many studies like the Webcast, but still, this is not only MCA, of course, but still you face the problem that you have like 20% completely occluded aneurysms. So I think still, if you look for MCA treatments, there is a problem for these endovascular solutions of the incomplete occlusions and the recurrency rate and retreatment rates. So we move forward and say, maybe flow diverters, would that be a solution for MCA aneurysms? And I am a big fan of flow diversion, and we were also involved in some development of flow diversion, so we have been using it since a very long time. So, so to conclude, first, what we have found at our institution, that MCA bifurcation aneurysms, flow diversion is not very effective. And one aneurysm that can be more complex or difficult. So that might be a good indication for selected cases. And interestingly, why a aneurysm bifurcation aneurysm would be not so very successful for flow diversion. Actually, this was well studied by this group from France. It was recently published. So basically what they found, if you have an asymmetric, this was a CFD study, if you have an asymmetric bifurcation, that's more like a situation in an M1, there's a high impact on hemodynamic flow by the flow diverter. In a symmetric bifurcation, that's less. That might explain the difference in results. So here is a small series from our center, flow diverter results, and we found it's not a large group, but we found that in bifurcation only 50% occlusion by flow diversion. And actually the same results were published by a Turkish group, satisfactory occlusion rate in bifurcation aneurysms. So M1 probably could be interesting. This is a young lady with multiple aneurysms, had a rupture of an ACOM that was coiled. And so this was like 8 years ago, and I wanted to clip this aneurysm, so we opened up and this was completely calcified and all the clips slipped, and said, I'm not so happy with this. And so we shifted towards endovascular therapy, and we put here a flow diverter. And at 6 months, you see a very nice occlusion of these aneurysms. And it looks a little bit weird here. It is cortical branch. And actually, if you look at the distal part here, this is at or before flow diverter implantation. You have here this cortical area, which has changed afterwards. So it's definitely a flow redistribution. So there is a little bit less flow in that artery, but the lady was doing fine. She was neurologic intact, and you see here she has made her own bypass through pile collaterals from the posterior circulation. A short note on MCA aneurysms, additional MCA aneurysms. One of our fellows did a very nice research on additional aneurysms in patients with the subarachnoid hemorrhage, and especially the MCA aneurysms have a way higher risk as expected according to FACES score. It's about more than 3% per year. So that is, I think, a pretty good indication for prophylactic surgery in case of multiple aneurysms and previous subarachnoid hemorrhage. This lady also, after subarachnoid hemorrhage of a PCOM aneurysm, inferior M1 aneurysm, she wanted to be treated as a flow diverter. She didn't want to have clipping. So that's what she got. Difficult to see maybe, but here's a 2 millimeter flow diverter. After 6 months, you see it's a little bit regression, but not occluded, but after 4 years. So it took quite a while. And there you see now the aneurysm is more or less completely occluded. She had a mirror aneurysm on the right, MCA, and also put a flow diverter here at the M1 trajectory. And after 1 year, that was occluded. This is a more difficult aneurysm. I think the typically superior pointing aneurysm with close M1 aneurysm with close contact to the striates. Probably not a good surgical case because you can damage the striates. For clipping, it's very tiny and the angle is sharp. So we said, well, now with the modern flow diverters that are so easy to use, we used the Silk Baby Vista of 2.25 millimeters. And so we put it here. It went very well, but she woke up with a slight left-sided hemiparesis. We did a CTA. I was concerned of occlusion of the covered branch because you see here this branch was covered by the flow diverter, but there was a thromboembolic complication. At least it was the image of thromboembolic complication, and so there was a defect in the CTP, but she made luckily a full recovery. So acute cases, we did also a couple of acute cases when there were no other solutions. This is a very difficult to treat M1 aneurysm, I think, with also the lenticular striates involved. And this is, of course, could be a possible bypass candidate, but we decided for an endovascular bypass, which basically a flow diverter is. But we also wanted to coil that aneurysm. So we do a jailing technique. We put a microcatheter here in the aneurysm. Here is the wire for the flow diverter. This was the over-the-wire flow diverter, which now does not exist more, but the old generation flow diverter. We do a very long one, deployed it, and then did kind of a loose coiling. We didn't want to do a high packing because we're concerned about the striates, but we got a nice remodeling, and basically the striates were patent. And he had a tiny lacunar infarction, but recovered pretty good from that, and this is the 6-month follow-up. So we're a little bit optimistic about the acute treatment with flow diverters on a ruptured aneurysm. We thought, well, that worked pretty nice, but we did a research with more European centers, also one US center from Dr. Waklow. I was a little bit shocked of the results we saw in this, if we collected the data, 44 patients. So we had 27% procedure-related permanent neurologic deficits, of which 11% rebleeds. So this is not the first choice treatment, only when there are no other options. Here, this is a fatal case of flow diverter and in multiple aneurysms, family history of aneurysms, symptomatic, giant, partly thrombosed, right ICA aneurysm with a MCA aneurysm. So the plan was here to coil that MCA aneurysm in one session, put a flow diverter. But for some reason, we were not able to access with a microcatheter the MCA aneurysm, so we decided to clip that later and to put only flow diverter. Then there were issues with the delivery wire of the flow diverter system. It constantly went into the MCA aneurysm, so we had to take the flow diverter out and had to go very distal into that branch to deliver the flow diverter. So that's what we did. We ended in the M1. We did a run afterwards and we had a wire perforation. So we had to do a balloon occlusion, reverse the heparin and give platelets. We're not very happy, of course. After 10 minutes balloon inflation, it seemed to be okay, but we waited a while and we got reopening of the site, so we had to occlude it with coils. Express CT looked not too bad, so we said, well, maybe this is not a big problem, but then I think we maybe made a mistake. We should put probably an ICP monitoring and monitor the patient, but so we didn't do that. So 4 hours post-op, she got a dilated pupil and the CT shows further bleeding. So we took her to the OR, decompressed it, but didn't help a lot for her. She passed away. Like I said in the beginning of the flow diverter, this is like a case 8 years ago. You were very optimistic. We thought it was the perfect solution for maybe all the aneurysms. So this is a incidental finding. The patient didn't want to be clipped. So we said, well, let's put, the plan was to put a flow diverter here. So we did an exchange maneuver first with the Prowler 10, we went into the upper branch and then exchange for the flow delivery system of the flow diverter and put here the flow diverter. We changed the anatomy, of course, but the patient did well and this was a complete occlusion. There's a rare aneurysm just distal from the bifurcation. So it is like a side wall. So flow diverter and worked for this case. But the real bifurcation aneurysms, we were less successful. This is a lady that had a rupture of this larger aneurysm that was coiled, but she had two tiny aneurysms, and one of those was on the bifurcation. So we put a flow diverter here in expectation of being successful, but that actually didn't work that well. Maybe we skip this for time reasons. So basically, in summary, and also what here was found in a systematic review meta-analysis. So you find a little bit higher occlusion rates as compared to stent-assisted coiling with flow diverters. It's approaching 80%, but you have a 10% complication rate in this systematic review. So again, use it for selected cases and definitely not, I think, for an MCA bifurcation aneurysm. So in conclusion, the endovascular treatment of MCA aneurysms, especially in Europe, we have many devices apart from just bare coiling. And so it's difficult to choose. And I think the approval in Europe has been too easy. That's not possible anymore now. There is a more strict rules to enter the market to get CE approval. But the devices, I think, have now, until now, most of them have a low evidence, especially of long-term efficacy. So we need data to see how it works. And of course, we have data, long-term efficacy data for clipping. But of course, there are complex cases, and there is definitely an indication for selected cases. And there, I think flow diversion seems to have the highest aneurysm occlusion rates. So thank you so much for your attention. That was my presentation.
Thank you very much, Dr. Josh. It was really presents both the surgery and the endovascular case, and a lot of techniques that you present. So next is should be questions. Is there any questions from the panelists?
Okay, thank you, Professor Jost. You skipped the result for the eclipse.
Yeah.
I want to know it.
I can go back. Of course, I will. Because I thought maybe it was a little bit too long time, but.
No, we have lots of time. No problem.
Let me try to do it again. Screen share. No, the reason I skipped because here we go. So because we cannot use it yet for MCA bifurcations, but
okay.
Thank you for your question, because basically it is a flow diverter technique, but it's not a tubular. It's not a tubular device, so it's more like a shield or a plate with feathers. But this is the aneurysm neck cover that you can see here, and this has a 30% metal percentage, so it's similar to flow diverter, but it's not abraded. So this is the aneurysm. This is the anchor part that anchors the device in the side branch. So basically, it works like a stent now. This is the new generation. So you put your catheter here in one of the side branches. You can choose. This is a basilar tip now. So the device is now comes in a 027 catheter. So I think it's a little bit too big for a MCA aneurysm. So for basilar, it works well. So company is now working on an 021 catheter, which probably is possible for a MCA, depending on the anatomy. So basically here, you put here the device like a normal stent, comes to the catheter, so you unsheath it. So, and then it's mounted on a delivery wire. It's like almost like an acai wire, which you can torque. So then you push it with that wire into the other branch with the help of the catheter. So typically like a 45 shaped catheter will be helpful. And then you push it into the other branch and drag it. So in order to have a complete neck coverage. So the advantage is, of course, you have your flow diverter properties only at the neck of the aneurysm. And so actually we investigated that the results of 24, so it's not widely used because the previous generation was a little bit more difficult to use probably. So we had 24 patients in the European Center as well as in Canada. And I think it's promising because we had a very nice high occlusion rate of 95% MRS, so Raymond-Roy score 1 and 2. So that's about the eclipse, but again, it's not for MCAs.
So I noticed that one patient died due to guide wire perforation.
Exactly.
Yeah.
Yeah. So that's so that's the old system, was an over the wire system, and like in older stents, you can have this distal wire perforation that we. So the newer system is not an over the wire system. It's like what you saw in the video. And so this was very sad, of course. It was a very distal perforation, and I was there. It was in the UK, and we missed it. You clearly, hindsight, could see it in the angio. It was a carotid terminus and very distal at the pericallosal artery. There was a perforation. Yeah.
So do you need to deploy it to use some electronic things?
Yes, exactly. So it's electrolytic deployment. Exactly. Yes.
Okay.
Like a coil.
Mm-hmm. Okay. Thank you.
Yeah.
Just thank you very much for your presentation. You are really I agree with you with your comments to the new crazy device to endovascular and the critical point of view of the surgery of vascular, what is better, what is not better. I agree with you with your comments, but one question. In Holland, you are experienced and you are the first center or the good center to the bypass with Professor Tulleken with ELANA system. What do you think? Where is your opinion with the effectivity of the bypass with ELANA or not ELANA system? Where is your control or your opinion with the patient come to Holland and treated with bypass? And this is the fantastic result, or also have a critical point of view in your opinion? Thank you.
Yeah, so to be honest, we of course, don't use the ELANA ourselves because Tulleken, although he's retired, but his center and now Professor Bart van der Zwan is doing this technique. So in the early years, we did refer patients to Utrecht because it's 100 kilometers from us to do ELANA bypass. But actually, in Utrecht themselves, they do only few ELANA bypass. So it's really decreased, and the technique is very beautiful. But it's so they do mostly like the techniques like like Professor Bingshu described, and so it's maybe a little bit sad because it's a beautiful technique. It's a great idea of Professor Tulleken, but even at their center, as far as I know, they don't do it. They do it only a couple of cases per year, and most of them as non-ELANA. So they have very nice, still they are working on it. So they have the CELANA, the sutureless ELANA technique. And so, so they are still working on further improvement.
May I comment on that?
Yeah.
We were doing in Helsinki, ELANA. We learned from Professor Tulleken. We made maybe 35, 36 cases. We gave up because it was too complicated for us. I think only Professor Tulleken could do it, so because it was so difficult to get the flap. The idea is wonderful, but in practice, the same happened also in Berlin and in many other hands. So it was not widespread. And now I hear that it's also going down in Utrecht. So
Yeah, exactly. That's true. Yeah.
yeah, it is maybe too difficult technique. Like Subin said, that it should be simple technique. This one we can manage. One thing about the comparing endovascular and open microsurgeries is the economy. The poor people cannot have endovascular treatment around the world. This is one of the drawbacks. It is extremely expensive as compared to open microsurgery. This is everywhere in the world where I have been working, and I see that, for example, in Nepal, people didn't have even money for a clip, not to speak about endovascular surgery. In China also, who has open microsurgery? Poor people without insurance. They have clipping endovascular surgeries reserved to those who are more wealthy. So we are speaking about the first world treatment here.
I agree. Yeah.
Okay, this is my comment. Yeah, thank you.
Another comment, just in Netherlands, you are another NeuroInterventional, have a lot of experience with web devices in middle cerebral artery. And he come one time in Madrid. I very surprised because never talk with the recanalization of this device. What is your opinion with endosaccular device and the rate of recanalization?
I think it's a huge problem. I think it's a huge problem. And so we have limited experience with the web because we have our doubts about the efficacy, especially in the MCA, because there are alternative treatments. And so, like I showed you the case, that's why I wanted to show you in the beginning. But now we have changed. We've seen many devices and the efficacy is doubtful, and especially long-term efficacy. For the web, typically we have many cases that after 1 year, it looks perfect, and the problems arise after 2 years. And so I think we have to wait a little bit, but we've seen that a couple of times, and for me, now it's clear. We only do it in selected cases when there is no other option. For example, if you have the ruptured wide-necked basilar tip, you can put, of course, coils in, but you will sure there will be a recurrency, and recurrency probably we would treat, of course, with eclipse. But in such cases, you can do not an eclipse in an acute stage, but you can do a web for a ruptured basilar wide-necked basilar tip. And so there are other cases that it's, especially in an acute stage, that would be helpful. But I'm really concerned, and I think it's important to see long-term follow-up, because that's what we in our series see is a problem. Good question. Thank you.
So, is there another questions? If there's
I
no,
just want to comment that the follow-up is the key to see something. You have to follow up the cases many years, and this is lacking in most big countries. And you should not publish your cases immediately in Facebook or LinkedIn or WeChat, whatever. This is nonsense. You should have follow-up for the cases to show that you are doing well. This is only advertisement and not the reality. And this is not good for the patients and the medical society community. But thank you for your critical, good lecture. It was very nice, Jost. Thank you.
Thank you.
okay, so maybe let's move on to our last topic by Dr. Luis for basic point. He also the cost director of the NEURO IMC. He's a neurointerventionist from Madrid, Spain. He will give a talk on endovascular management in middle MCA aneurysms, part 2.
Okay, I like to try. Is okay?
Yes.
Yes. Thank you very much, every professor to come every week to this NeuroMC. Just a minute, because it's just a minute. This is not the first slide. First slide is this. Okay. I like to present some examples where it is my experience and my critical point or difficult to treat it, this middle cerebral aneurysm. In our experience, I started with coiling in '92 at the same time of Gudigliemi, and I am very happy with the coiling to the aneurysm, but the problem is the recurrence. Also, what time I treated the aneurysm with the PGA material, or PGA is the matrix, and this material have a very high recurrence of aneurysm, because have a thrombus at the set time you place the coil, you produce a thrombus, a fresh thrombus in sac. Also, I have experience with fibered coils with at the beginning is Dendron company, now is I think is Medtronic. In July 2005, and the difference of the fibered coils is the material is nylon, and this nylon produce aggregation, plaquetted aggregation in the sac. And this is the only reason is different results to another course. Dr. Henkens in Essen, now is in Stuttgart. Professor Hans Henkens have a lot of experience of this fiber coils, but I don't know why the industry don't like to take again this material. Don't have many possibility to have these devices. I don't understand what is stop. Probably is the economical reason. This is one case treated in 2005, middle cerebral arterial aneurysm. I treated in acute phase, 59-year-old, only 2 coils, one basket with Tetris and one fiber coils. This is the time of the intervention. And after embolization, and 12 days later, the control is totally occluded. In my experience, 90 or more, 95% of the patient is treated with assisted balloon remodeling. The reason is you have possibility to protect when you introduce the coil to the rupture, and the second is more easy to packing the aneurysm. The most important to have a good result and stable is high packing of the sac. about the maximum is 50% of the surface. It's not possible to pack in 100%. Sometimes you are inside the coils, you are flow, small flow. It's very difficult. This is the reason I use the balloon to have a dense packing of coiling. The balloon is placed in 1 or 2 branches. It's possible to change the branch. And the idea is to use the maximum number of coils. This is the control. And this is the standard result after embolization. But sometimes these patient examples come in emergency for several headaches, many times in the hospital, not bleeding, but have at least middle cerebral aneurysm. This is oblique projection, superior branch, inferior branch, aneurysm. But the problem is inside the sac, you are the branch. And this is difficult to surgery, in our opinion. And to start the treatment, I put the balloon remodeling. You are a loop in sac. I inflate the balloon distal in M3, and then with the balloon is inflated, I remove to have a good place to the catheter or coil. I coil in the aneurysm. Also, a second balloon in the inferior branch, superior branch, inferior branch. But anytime when deflate the balloon, the coil going to the neck and close the exit branch. This is the reason which is treated by double stenting. One is superior branch here, and the second in the inferior branch. And jailing. Sorry. This is the stent, superior, inferior. And then I treat it with coiling, packing. And this is habitual technique. Sometimes you are difficult to see this lenticulo-striate artery, but it's external, it's not medial. And you don't have symptom, the patient. By coiling, this branch disappears, but the patient don't have a symptom. It's asymptomatic. This is the control. In lateral view, and good flow, distal flow, and size of the vessel. Asymptomatic. But sometimes with the manipulation, the problem is the thromboembolic migration. Several distal, to treat it is or several distal thrombectomy with many branches with a balloon, stent retriever, or aspiration. This is small aneurysm, bifurcation. This is work projection. I place the balloon in superior branch, coiling, and inferior branch and coiling. This is the result, but in late phase have some stenotic or diminution of flow in this branch. Look, after 20 minutes, and then you don't have vascularization in this part, in motor area. Don't have very, this is ischemia in this region. Don't have good collateral circulation. And treated with a balloon and aspiration. This is another case. This middle cerebral aneurysm also have a loop to go in distal part. And then place the balloon, place the coils, but after procedure have reduction of flow on this part. And the reason is some compression in this part of the vessel. Angioplasty here, but also have a small thrombus in this part. And many manipulation to open this vessel. We are also early venous pathway. Another ischemia from this branch. I be careful to check every region after finish the procedure to treat this. You are early vein, angioplasty, and final result, you are a good circulation, also in this branch, no ischemia, and this is the control of aneurysm. Only some subfusion of contrast and a small distal ischemia asymptomatic. But sometimes it's possible with the manipulation also rupture the aneurysm or rupture the middle cerebral artery. And this is a case with endovascular rescue. The main cause of break of aneurysm is advance the catheter or advance the guide wire. When you place the catheter and you remove the guide wire, sometimes advance the microcatheter. Also, the hyper pressure the coil, imperinflated balloon, or upper pressure in stents. This is the reason every time I have the balloon remodeling support to help me in the procedure. In 1997, Moret related the complication to the technique is a favor, but intraoperative rupture in this study is 1.5 mortality at this time, and 33. Now this is intraoperative rupture of aneurysm in general, and morbidity. With balloon, decrease this. This is one example of rupture, of coiling. You place the balloon and you place the coil. This is another patient, is not bleeding story, young patient, MCA aneurysm. This is a case. Small aneurysm is, of course, this aneurysm is to open surgery, but I don't know why the patient decide to treat it by endovascular approach. Endovascular treatment. Start in 10 o'clock, 20 minutes. I'm coiling 10 and 48. The coil is too bigger. And this is the coil going out in the artery, middle cerebral artery. This is the balloon, guide wire and balloon. This is the coil, and some loop part of coil going here. When remove the coil, the catheter advance. And the patient bleed, a small bleed. This is the bleeding, distal part, 11, during procedure. And my colleague inflate the balloon, but I inflate the balloon too much and rupture the middle cerebral artery. This is the rupture of the middle portion of the M1. At this moment, I inflate the balloon in the terminal part of the carotid siphon in this point. Check contralateral injection with the left carotid to check to stop the bleed. Continues the bleeding, the contrast is here. And I inflated anew and replacing the balloon to this part, this, to preserve the anterior choroidal artery. Not bleed. I place in angio suite external ventricular derivation. When the balloon is deinflated, the patient have a new bleed in this part, and this is false aneurysm, dissecting. This is the bleed, this is dissecting. I decide the reconstruction with a stent, and this is the reconstruction of the vessel, but still a little. This is good, but few minutes later, have a new extravasation and dissection in aneurysm and growth. A few minutes later, growth. I decide at this moment close the middle cerebral artery if the origin and preserve the choroidal, anterior choroidal artery, have a poor collateral circulation. This is the final control of also craniectomy, decompressive. And this is 6 months, 1 week later, CT scanner. And this is 2-year MR control with infarction, left arm hemiplegia, leg paresia, walk with height. A fusiform aneurysm in middle cerebral artery, a small fusiform aneurysm. This is a case, probably the flow diverter is possible to use. This is oblique projection. This is the fusiform M2 aneurysm, AP view. I use every time one grid wire and the second to place the baby silk material. This is the baby silk place. And this is the control. Few months later. This is the only good result. This is the CT scanner, initial CT, angio CT. But sometimes the test occlusion balloon is possible to sacrifice the artery. This example, this is a high giant aneurysm come in my hospital to treat, but 1 week later, a spontaneous thrombosis because you unopen the collateral circulation. Probably is decreased slowly in 1 week difference. Another fusiform aneurysm. This patient is treated by myself in Cartagena, Colombia. I decide to treat it only with coiling in the origin of the aneurysm. And this is a collateral circulation without symptom, without deficit. Finally, I present a ruptured aneurysm after web implant and the management of complication. This is 61-year-old, asymptomatic, not bleeding. This is the aneurysm, large neck, branch born inside in the neck. Probably it's not good to treat it, but it's my first case, and the proctor come will help me. I decide this is good case. No, I don't know. Okay. This is working projection. The catheter, guide catheter. And when I place one guide wire here, and the second with the coil, with the web here, and during the deployment, the web move, the patient bled, small bled, but this is the control angine immediately, high rupture. Very quickly, my friend compression, then manual compression of the neck, and place a balloon in middle cerebral artery, inflate the balloon to stop the flow. This is the web. No detached. And in lateral view, the web is outside the sac. Is in subarachnoid space. I decide to replace the web, advance the balloon, inflate the balloon, finally, I place one Atlas stent, and this is the web inside. This is the remnant of sac. This is a CT angio suite. You see here in axial view the Atlas stent. The web is not totally open, distal part. This is the final control. This is 1 year later. Some better reconstruction. In 2005, the remnant is stable and the patient don't like to treat it anymore. And the patient is total asymptomatic. This is the control also with magnetic resonance 5 years later without ischemia or deficit. Thank you for your attention. If you have a question.
Assalamu alaikum. I am Major Maimoona Qayyum from Pakistan. I am also a gynecologist. I want to ask a few questions related to a case that was that we received a day before yesterday. We received a patient. She was 37 weeks pregnant. She had previous 2 cesarean section. In her previous cesarean section, when the spinal anesthesia was given, there was a bleed in the spinal canal that was, however, tackled and that appeared as an emergency. After the cesarean, when the CT scan of brain was done, it was found that the basilar artery has an aneurysm. She was advised for the surgery. Till that time, I don't know the surgery. Today, I understood the different method that you have showed in these lectures. And she was advised that she should not produce any more children and she should get the treatment of her aneurysm. But the patient did not obey the medical advice. And now she reported again at 37 weeks with aneurysm and she came for the cesarean section. At that time, we discussed the case with the anesthetist, with the neurosurgeon, and also with the hematologist and vascular surgeon as well. They said it is not possible at the moment to do anything. Once her surgery is done for the cesarean section, then she can be treated. But previously she has raised blood pressure, and this time she also has raised blood pressure. It is decided that the whole team is going to operate after taking a high risk consent. What is your advice in such a case? How should we follow up, and what are the problems that we can have during surgery, during cesareans? Because I am a professor, I teach the students, I teach my postgraduate trainees. So I want to have a knowledge about obstetrical angle so that I can teach better my trainees and my students.
Just, do you want a comment?
Yeah, I want your comments. The advice which is required, and the if we receive such cases in emergency, and if since I am working in Pakistan Army, at that time we are posted in some small stations and people report in an emergency. And in such a situation, how should we handle the case? Being a gynecologist, being
Thank
an
you, ma'am. Thank you,
obstetrician.
ma'am. Thank you.
So the problem is the patient has a basilar tip aneurysm. Did I correctly understood? Yes.
When she reported first time, it was not diagnosed. Later on, CT scan reported she
Okay,
has.
thank you, ma'am. Thank you, ma'am. Okay, go ahead. You want to comment on this, or should we move on?
I think what she said that the patients have 5 months pregnant and she was found basilar tip aneurysm.
Yes.
She was
So
at,
with
she
your
was not 5 months pregnant. She was 9 months pregnant. 37 weeks. She was.
Okay, so 7 weeks, 9 months, right?
37 weeks, 9 months.
Okay, 9 months, and she have so she found that she have a basilar tip aneurysm. Does it rupture or non-rupture?
Still, in the previous operation, she had a small bleed, but at this time she reported in an emergency again, in spite of the counseling and all that she should get operation and she should not produce, but again she reported in an emergency.
So
with all previous paper in her hands.
So the aneurysm have already been secured by the surgery, right?
No, it was not secured. It was only diagnosed.
Okay. Okay.
Okay, no, I needed the angio diagnosis, but it's different. It's different. The time of treated is depending. If you see the aneurysm, it's possible have MR to diagnose, and your MR, and you see the morphology of this aneurysm, and then you decide, see the patient is bleed, is not bleed, and then you decide, see what is the best treatment. If you like, it's possible angio endovascular treatment, or you go into the open surgery. It depends on the morphology, localization, and see the patient is bleed.
Okay, thank you. Okay, Warwick, let's move on.
Okay, so is there any other questions from the panelists?
Luis, thank you. This was a very nice presentation, especially the challenging cases and difficult moments in the Angular suite. I can understand. So it's nice what you showed. Concerning the web, you think it was the tip of the web that kind of peeked through the fundus of the aneurysm, you think, because it was it twisted like that? So it was basically the tip, or what do you think exactly what happened there?
I think it's the tip. For me, the tip is a dagger because it's very stiff, the support of material, and the small movement is possible to rupture the aneurysm with one coil or one guide wire, but the tip of the web is very stiff. Also, when open, is like a very high movement. But I think that the web device is only for special indication. And my critical point is you are many recurrence of the neck.
Yeah,
is my opinion.
No, the same rupture issues. I don't know exactly the numbers, but that was told by an American neurosurgeon that was not reported. That were not cases from the Webbit trial, because there was only one patient with that had a later thromboembolic complications. The results were very good, but that after the Webbit trial, everybody thought it was so safe and easy, and so that probably they were a little bit maybe liberal in using it, and the way they used it, that they saw after the trial ruptures, intra-procedural ruptures, because maybe people were too enthusiastic pushing the web into the aneurysm, and it's so that's something that was not described in the earlier trials, but you see it, yes.
Yes, and I think in the community and the NeuroInterventional community have a discussion. Is not is stupid discussion. The reason to treat it with the web is because don't use the antiplatelet therapy, and this is not total true, because in acute phase, when you close the aneurysm with coils and then you place for example, Atlas, later it's possible to inject the antiplatelet, intravenous antiplatelet, and treat the patient with the antiplatelet. I don't have problem from this. And I think the risk to treat it with one device, a stiff device with web or another endosaccular, is most easy to treat it with the standard technique, coiling, balloon, or Atlas, whatever you want, is my opinion.
Yeah.
Okay, Warwick.
Any other questions from the panelists?
Do you use always balloon in any aneurysm, or?
Yes.
Always, so like 100% of the cases.
Always. More than 95%.
Yes. And which balloon now? Which balloon is your favorite one?
The
Transform maybe, or Scepter, or?
No, Scepter, no. Standard balloon of ball balloon or probably balloon. And when I don't possible to go far, distal to aneurysm, I place the balloon in the middle cerebral artery to protect in the case I have ruptured aneurysm.
Yeah.
So only for this.
Thank you. Good.
And without heparinization.
Yeah, go ahead, Juha.
Just concluding, it seems to be hard contact sport, whatever you do. those who have no complications are not doing anything or cheating.
I agree.
Totally.
I think we can end it, Rolex, on that note.
No, I still in the learning curve. So yeah, I have a few rupture in my hand a few couple times. Still have to get used to that.
Juha, the next session, I like to talk, if you want, of the cerebellar aneurysm and middle basilar aneurysm. O sea, basilar aneurysm and cerebellar. Restricted.
Which aneurysms?
No. Every. Cerebellar and basilar. Small aneurysm.
I don't catch it.
Yes, you are cerebellar, you are pica, no?
Okay, vertebral pica. Oh,
Vertebral pica and middle basilar, you know,
mid-basilar.
middle small basilar aneurysm. No dissecting. Standard aneurysm.
So we have to come to conclusion what we speak. Below the lower part of the vertebrovascular system or not, I think we have done basilar tip aneurysms we have done already.
Below you take her.
Okay, we can talk about that later.
Okay.
Okay, so if there are any other questions from the panelists, thank Professor Juha, Dr. Luis, Dr. Beans, Dr. George for the really great and presentations today. Is really amazing, and thank for Dr. Binsu for the simultaneous translating to Chinese, and thank for the panelists, audience, and especially the Chinese audience. And hopefully we will meet for the next sessions in which it will be interesting as well and really helpful for like freshman neurosurgeons like me, especially vascular. Okay.
Thank you. Bye.
Bye.
Thank you, everyone. Great job, Warlix. Thank you.
Thank you, John.
Thank you, Juha. Thank you, Louis.
Oh, I saw the audience, my old friend Giancarlo Pera
Okay, let's.
from Palermo, Sicily. Can you hear me, Giancarlo?
Yeah. I don't know. Can we hear you? Where's he at, Juha? What?
Giancarlo Pera. Giancarlo Pera in the audience.
Oh, okay. I don't know. Oh, okay. Okay, I see what you mean. Let's see here.
Reinaldo from Mexico.
From Palermo, Sicily.
Oh, okay. I don't see him.
He left.
Oh, he left.
Okay. That's okay.
Very good. Thanks a lot, Juha.
Thanks. Bye-bye.
Thank you very much. Nice to meet you, professors.
Hey, Patty,
Thank
how
you.
you doing? How you doing, Patty? You met Juha, right?
Yeah.
Okay.
Hi, Luis.
Yes.
Luis.
Yes.
Now the total audience number for this 4 sessions is 7,851.
Hey, all right.
Hola.
All right, way to go.
Yeah.
Andale, please. Andale. Very good.
For the four sessions. Yeah.
Yeah, thanks, Ben. Great job. Thank you very much.
Thank you.
Okay.
Okay,
Thank
Louis, are you there?
Yes.
Hey, Louis, I'd like you to meet somebody. Joanna, are you there?
Hi, John.
Hey, Joanna,
Hi, everybody.
I'd like you to meet Louis.
Yes.
Joanna is thinking about NeuroInterventional radiology. She's from Finland. She's a neurosurgeon from Finland, from Helsinki.
Hi, Professor Lopez-Ipor.
Yes. How are you?
Amazing. I'm okay. Your presentation was again outstanding. It's always a pleasure to see your presentations. They're so detailed and so outstanding. It's like, wow, all of you. I'm really happy that you do these webinars.
Yeah, you know, she went to that conference, Louis, in Paris, the big neurointerventional radiology conference.
Link Paris.
Link.
Link.
Yeah.
Link.
But this is a small group of the neurosurgeon and neurointerventional of the top level. Every week come new different neurointerventional, and I have a support, a high support of Professor Herniemia, Professor Bingsu. I am very happy.
What's going to happen? What's going to happen this year, Luis? Are you going to have an online conference of neurointerventional radiology? I know you're not going to have the in-person conference, right, in Madrid?
I start to work in at the beginning in February,
Okay.
but it's online.
Okay.
It's not possible, but I like to discuss with you because I have many conflicts. I like to discuss before with you.
Okay. Okay. We'll work it out. You got a great crew there.
Because this your system and your panel is I think is work very well.
Yeah.
Work very well to many people.
Yes.
And also it's open to us, to China, to India, Pakistan. I like it. It's
yes. Yes. Yeah. Thanks to Ben. Warlex, you great job, Warlex. You're great, man.
And the oral law, the design of oral law is fantastic.
I'm sorry, I'm interfering. My question is still same and there. I think you can give me in writing the answer of the my question. So what should be the approach?
Yeah, hold on, ma'am, hold on. We're done. We're done with the conference now. Okay. If you want to talk to a doctor personally, you want to get their email address?
There's one question that I want to ask. What should be the approach during pregnancy, during surgery, and the postnatal period? I want the answer of this question. If whoever is, I think, is the right person to answer this question, I would be highly obliged. Thank you.
Okay, I don't know if someone wants to handle that.
Okay.
No, thank you. Okay, let's see. Yeah, ma'am, you can put your question in the chat if you'd like.
Maybe she can put the questions.
Yeah, put the question in the chat.
Yes, we are willing to accept the question. You can put it, and maybe after the sessions, we can send the questions personal to a doctor who would like to answer that for you, ma'am. Yeah.
Okay, thank you. I'm going to write it in chat.
Okay, very good. Very good. Yeah, Warlock said between, you got to fill in the time sometimes with talking and stuff like that. You know what I mean? It's uncomfortable. It's uncomfortable. I know what it's like.
No, but I understand she really want to ask, I think that because last week I have I think 5 months pregnant woman, and she have the vertebral basilar.
The same thing, huh?
Dissecting aneurysms, but this case is cannot be operated. So the only choice is we have to sacrifice by endovascular. So it's really challenge, but it cannot be only asked to talk. It have some details radiologists to care about what is the protocols to talk about the risk of her pregnant, her baby, how to give an advice.
Okay. Well, I think she's writing the details, so you can make sure you copy that if you want to answer that question, Warlex. Hey, Patty, how you been?
Okay.
Warlex, I'd like you to meet Patty. I don't know if Joanna's still around. Hello, Patty, you there? She's a female from Argentina, neurosurgeon.
Yes, I'm here.
Yeah, you girls ought to stick together. I'd like you to meet Warlex and Joanna if she's here. Are you here, Joanna? I think she left. But anyways, this is Warlick's. Patty?
Learn Chinese sometimes.
What is that? What is that sound there?
I don't know.
Oh, I think Ben is translating. Okay. Yeah.
I plan to learn Chinese sometimes. Okay, so
I don't have very well
Internet? No,
microphone.
tu internet no es bueno?
Yes, I don't have internet well now.
Oh, okay. Okay, pero
But-
bienvenidos.
Gracias. Gracias. Y congratulations for every professors with the themes. Sorry, my English is very bad.
No, that's okay. We can understand very well. Very well.
But thank you very much.
Very good. Very
Muchas
good.
gracias por tu participación, doctora Pacheco.
Sí,
A usted, doctor, a todos los doctores, muchas gracias
sí,
por su
ella
experiencia compartida hacia nosotros. Son pequeños trucos que eso lo da solamente la experiencia y no se los encuentra en un libro.
Sí, ¿tú conoces neurointervencionistas de Buenos Aires, Patty?
Sí, conozco. Rolando Cárdenas es uno.
Okay.
Después está... Hay varios, hay muchos.
Varios, okay. Probablemente Luis conoce algunos en Argentina.
Lilik,
Pedro
sí,
Lilik.
Pedro,
Sí.
sí, hace una semana está aquí.
Sí.
Dando una charla.
Yeah, and the session is now is in YouTube. The first two sessions is in YouTube, ¿no?
Sí. Sí, está grabado. Editamos, pero está lista.
Perfecto.
Está lista ahora. Qué lástima no puede ir a España. Qué lástima. Yo tengo sueños de Madrid.
No. Don't worry. Probably it's dependent. Si it's possible, you come to Madrid because I check with I invited with another place in Madrid, a big
Okay.
a big hotel and special. I train me few weeks and for me it's not expensive. You're invited, and the only problem is the security, health security
Right.
for travel. Only this.
Sí. See, Luis tiene he has a conference in Madrid. It's a real Madrid experience. I mean, you not only go to the conference and get people like you speaking and Jost, but Luis brings you out to the Prado and you go out to the Flamingo. I mean, it's a real Madrid experience. It's more than just a conference.
And
many una conferencia.
Okay. Bueno, okay. Thank you very much for your
bueno.
And see you in 2 weeks.
Okay. Bueno,
Thank
okay.
you, Dr. Boralux, for your help me and the very nice poster. Incredible.
Really helpful anyway. Yeah. I still practice on this stuff. Endovascular surgery.
Bye.
See
you.
Okay, see you, Louis. Okay,
Yes.
I'm going to stay here. We have another, actually, we have another neuroanatomy. Let me show you here. Let me see here. Hold on, Warlicks. Monday. A neuroanatomy conference with Victor Hugo Perez. Here it is. Okay, there we go. Let me screen share it now. and I'll put the information on the screen how to get in there. Okay, this is in 1 hour. Victor Hugo Perez, he's a well-known neuroanatomist as well as a great lecturer. He in Spanish and English. He's doing this one in English. He does a lot of injecting of latex into arteries and veins, which makes it very easy to understand. And also we're going to have what's called a Kahoot quiz after the presentation, where Victor's going to go over 10 questions of the content of his lecture, and you will be graded. I don't know, what kind of prizes can we give, Warlicks?
I don't know. Trip to
A trip to Bangkok. No,
have Victor test now, so don't go to Bangkok. So
it's bad to travel now, huh?
even we are safe, but we have big protests in downtown, so don't come here.
Oh, okay. Yeah, nobody wants visitors. In Miami, it's the same. There's no tourists there. The streets are empty.
COVID like infections, but I want to go there anyway. Yeah.
Oh, okay. Very good. Anybody else want to introduce themselves or say hello?
So for the questions, maybe we'll talk later.
Did you get that question? Did the woman write it down? The question?
Yes. Yes. I think maybe if somebody's kindly to answer that.
Oh, okay. Which question is it? Can you ask? Maybe we'll.
Somebody is like Dr. Kumar like summarize for us. Patient is 37 weeks pregnant with unruptured basilar tip aneurysm. She should undergo cesarean sections following by basilar tip management. I don't know, by surgeries or endovascular. The type of treatment will depend upon aneurysm morphology, which decide on. Oh yeah. So I think so for if she's still here, Dr. Mamuna, if you have the information of patients, CT, CTA, or DSA, maybe it will be useful if you give adding more for other suggestions, so we can send it to our speakers to.
Okay, you got her email, right? Mamuna?
Well, so we should have her email, right?
Yeah, it's on the chat. Do you see it?
Okay, thank you. Send me in my email. My name is Mamuna. So nice to talk to you. Nice to talk to you.
You got it, Warlicks, right?
Yes, I got it, but we got
okay.
This
hey, can you wiggle your nose?
Huh?
Can you wiggle your nose?
What is that?